Welcome, everybody, to the Intactivist Voice podcast. And I feel so fortunate to have with us Dr. Jared Ross today. And he is an amazing leader in the Intactivist movement because of not only is he a doctor, but he is a Jewish doctor and has amazing experience. And Dr. Jared Ross is a board certified physician with over 25 years experience as a paramedic, a firefighter, and an educator. Jared is clinically active in the emergency medicine, EMS, addiction medicine, alternative psychotherapy. Jared has been invited speaker to over 100 national and international conferences ranging from core medical topics such as cardiac and respiratory emergencies, cost effectiveness, and medical ethics, which we're dealing with today, to controversial issues, including the clinical use of psychedelics, free speech, and academic medicine, and the treatment of gender-distressed youth. Dr. Ross is frequently interviewed for media commentary and has been featured by Fox News, The Daily Wire, The Jordan Peterson Show, and Jared is the founder and president of EMSEC, which provides healthcare counseling services. Dr. Ross is currently authoring a textbook on emergency pharmacology. Welcome, Dr. Ross.
Thank you, Dwayne. Thanks so much for having me. Pleasure to be on the podcast with you.
So we're going to get right to it with you, Dr. Ross. We're going to be respectful of your time and our viewers' time. And the first question is, what does medicine commonly get wrong about circumcision?
I think the biggest thing is that it doesn't question it, right? In medicine, we're scientists and we are physicians, and everything is driven by the science. And unfortunately, when it comes to circumcision, which is a word I absolutely despise and really try to avoid using, because it normalizes and medicalizes a procedure that is in no way normal, is disrupting normality, and has no medical benefit whatsoever, I would argue, even when it's indicated in a so-called emergency situation that there are less invasive approaches, even leading up to surgical approaches. I think our biggest problem is that we don't question it. We take it for granted, and we don't even think twice about this absurdity that we take an infant boy who's typically in his second day of life, we take him away from his mother and we cut his foreskin off. And no one stops and thinks, why are we doing this? Do we need to be doing this? Should we be doing this? It's just done. It's another check mark on the birth list. We need to talk about this in the medical community. That's absolutely the biggest issue here, is that amongst doctors, amongst nurses, especially in the labor and delivery units, we need to start having this discussion of why are we doing this? And unfortunately, I think the answers there are not going to be things we want to hear. I think there's financial incentives for the doctors, there's financial incentives for the hospitals. And unfortunately, I think a lot of this is driven by the labor and delivery nurses. And I think they have a conception, as I think most Americans have a preconceived notion that's ingrained by every exposure to male nudity, whether that be pornographic or not, that the normal male penis has no foreskin. They're just reinforcing their own view of normality onto these innocent little boys.
Which is the normality shared by the culture at large. And what term do you use? Because like you, I dislike the euphemism of circumcision.
It's absolutely a euphemism. I agree with that. I really like the term mutilation. If you look at the movement that combats female genital mutilation, that's the terminology they use. That's what this is, non-consensual mutilation of a child's genitals. I like that terminology. It's very accurate. And I know people will come to me and say, oh, but it offends the sensibility. It's guttural and really takes you aback. And I said, that's the point, but it's technically correct. And so I'm willing to settle for cutting. And I think you'll see that on the side that combats female genital mutilation as well. They'll say female genital cutting or genital cutting. Again, I think that's accurate, and that doesn't normalize it nearly to the degree that so-called circumcision does.
That's what I've been finding as well, is that the term mutilation, people want to argue about semantics. And this isn't about semantics. This is cutting the genitals of children. So that is accurate. Thank you for that. Why do many doctors stay silent about circumcision, even though they question the harms of it?
This gets back to the last question quite a bit. Is I think doctors are challenged to even question it. It is so deeply ingrained, it is so normalized, and it is so taken for granted. I think if you were to do a survey of medical textbooks out there, of anatomy and physiology textbooks, I suspect that for the American textbooks, the vast majority of what you would see would be mutilated penises. I think you would see intact or normal penises being the minority. And so this is so ingrained from such an early stage in the medical training, and probably in the pre-medical training, and probably even before anyone thinks about going into medicine or taking the MCAT or taking the SAT and going to college. Most Americans, men and women, take for granted that the penis doesn't have a foreskin and think that a penis that does have a foreskin is the outlier, is abnormal. I've heard slurs like worm penis used in a recent Twitter thread I was involved in. So I think it really takes some sort of sentinel event for someone to realize, wait, what are we doing here? Why are we doing it? And to start to close that cognitive dissonance and to question this. And then it's very hard to bring up. It's definitely not talked about. Again, everything else is on the table, right? We can talk about very controversial topics like vaccine hesitancy, and we can talk about all kinds of very controversial medical topics. But when we start getting into this, it just immediately is an area that we can't tread into. And I think that, as you mentioned, I'm a practicing Jew, and Judaism, questioning is such a deeply rooted part of the faith. Constantly questioning to learn and to doubt, that's fine and that's acceptable and that's encouraged. But this is this one sacrosanct area. I was at an event last week. If I went to any of the rabbis that were present at that event and started questioning this, I would be immediately shut down. That's the covenant with Abraham, period, end of story. And that's not, we can talk about kosher laws and why Jews don't mix milk and meat and don't eat pork and don't eat shellfish. And we can talk about observing the Sabbath and what we're allowed to do and not allowed to do on the Sabbath and different interpretations of that. And we can question all of this, but for some reason, when you start questioning male genital cutting, it's just shut down. And the same thing in medicine. And if you start to draw these comparisons between male genital cutting and female genital cutting, you also just completely get shut down. Everyone just starts saying they are not the same. They are completely different. And I will readily admit that the most common form of female genital cutting is embryologically different than the most common form of male genital cutting. But when you look at the WHO, the World Health Organization's classification of FGM, which I think is very telling that they don't have any system for classifying MGM or male genital mutilation. When you look at the World Health Organization's classification system, WHO class 1A, female genital mutilation, is removal of part or all of the clitoral hood. And that is embryologically the same tissue as the male prepuce, the male foreskin. And so for some reason, we can sit here and we can say, oh no, we can't even think about nicking female genitals with a scalpel or even with a needle, that's a felony and that's a violation of federal law, punishable by 10 years in prison in the US, and is unfortunately rising in the US. It's very unfortunate. We know that male genital cutting in infants is decreasing very slowly, but we are seeing some decreases there, mostly in the Pacific Northwest. And I think any progress is good progress. But unfortunately, we are seeing an increase in female genital cutting, and a lot of that's occurring in heavily Muslim immigrant communities, and even being done by physicians, unfortunately. And we're also seeing this in the West African immigrant communities as well.
It's the same to the child that are being restrained, their genitals are being cut, and they have a scar for life. It's the same for a girl or a boy.
We need to end this once and for all. You've got very developed countries, all of Western Europe, Eastern Europe, that don't do this. This is not a practice that is accepted, and again, unfortunately, is growing as you've had increasing Muslim immigration into both Eastern and Western Europe. But by and large is not practiced in those countries. And all of these supposed complications from not removing this tissue that has managed to remain despite 6 to 7 million years of human evolutionary pressures is not thought of. It is abnormal in these developed nations. So this is not an issue of first world versus third world. This is uniquely a Western issue. And by Western, I really mean American and Canadian to a lesser extent. And that comes from the Jewish tradition being incorporated into mainstream medicine. That comes from Muslim religious traditions. But I think a lot of it in the US comes actually surprisingly from the Puritans, who were really trying to push this as a method to prevent masturbation, of which there's absolutely no evidence that it does. And there's no evidence to indicate that the child masturbation is harmful at all. It's a normal part of child development. And I think as a responsible parent, it's your job to make sure that occurs in a setting that's culturally appropriate and safe for the child, and not happening in public or at school. But there's just no basis behind this.
There's no evidence for any so-called benefit of genital cutting.
Evidence is incredibly dubious. I mean, a lot of what Western medicine cites is these 3 large studies that were performed in sub-Saharan Africa by American physicians who went over there with big American universities, with funding from the US federal government, in an attempt to decrease the spread of HIV and AIDS. And they performed these surgeries on adult men who were voluntary participants in these studies. I think there's huge ethical concerns with doing this. One of the major issues here is that you can't adequately control for this. When you have a well-designed clinical study, you have to have a control group. You have a control group and an intervention group. And you have to design that control group in such a way that there's some degree of blinding. Ideally, you want what's called a double-blind study, where both the patient and the physician are blinded to whether the patient was randomized, and we talk about randomized control trials, randomized to the intervention group or to the control group. The problem is that when you have a surgical intervention, performing a control to that surgery is very difficult and ethically questionable. And so there are some trials that have done sham surgeries where they'll actually cut people open and sew them back up without doing anything else. And the patient then doesn't know what happened to them. But when you have the foreskin of the penis removed, there's no way to keep the patient unaware of that. There's no way to keep the treating doctor unaware of that. So even in these sham surgery trials, you can have a surgeon who knows whether they did the real surgery or the fake surgery, but then the doctor that's following up with the patient doesn't know, and they just see the same scar, so they don't have any idea. You just can't do that here. And when you subject someone to a surgical procedure, an adult male to a surgical procedure on his penis, and tell him not to have sexual intercourse for 5 weeks, that's going to confound your results. And he's not just going to listen to you about that. He's going to listen to you because if he tries, it's going to bleed. He's got a bleeding wound and a scar developing on his penis. There's just no way to adequately say that taking a group of adult men and cutting their foreskin off and giving them condoms and sex education pamphlets, and taking a group of adult men and giving them condoms and sex education pamphlets and not cutting off a part of their body are somehow equal and can be studied as equals. And then even if you can get past the control issues here, even if you can get past the ethical hurdles of well-funded first world nation doctors going into a third world country and performing surgery on people, whether there's true consent there and what those power dynamics look like, you have the very real problem that you're not only extrapolating this from the third world to the first world, but you're also extrapolating this from adult men to infants, not even to infants, to newborns. And so none of these 3 studies are worth the paper they're printed on. And I think are just so problematic. And that's not even to get into the authors of the studies and some of their ulterior motives from all kinds of personal perspectives.
Those studies have been debunked so many times. Unfortunately, they keep getting brought up.
They are. And I would agree with you that they're debunked. But unfortunately, I think that mainstream Western medicine views them as very highly valid and accepts them as dogma.
Thank you for that. And it's unfortunate that I think causation and correlation are getting mixed up with that one. And they're using African adult men as a precursor to infant children in the United States, which none of it makes any sense. You touched into this a little bit. What is your unique approach when talking to someone for the first time about circumcision? They might not even ever thought about it before, might not never know it's a harm, and they might think it's normal. What is your approach?
I think they think it's normal, right? This is really challenging, Dwayne, and I don't claim to have the answer here. I definitely have not mastered this myself. I've spoken with friends and family members who were expecting a boy, and I've actually lost some very close friends because I brought this up. Really not well received. I learned to kind of keep my mouth shut about it. And I actually mentioned this to a few very close friends who have had boys that they decided to have cut. One of them just had a second boy, I believe, a month or 2 prior. And he was really upset at me for not bringing this up sooner. Our friendship has fallen to some degree, I think, because of that. Because I think he had some regret about this, not really being informed about it. Again, I think most American parents, unfortunately, are very uninformed, and I think the medical system is happy to keep it that way. I mean, we do have a standard for consent, and that is informed consent. And even our surgical societies say that informed consent shouldn't be obtained on the day of the procedure. It should be obtained on the pre-op visit. So if you were to take that to pregnancy, that would be on the last visit before mom is planning to come to the hospital to deliver. So I think that's usually the 38th week. I'm not an OBGYN, so don't quote me on that. But you would talk about that during the pregnancy, and then you would consent for that before mom comes to the hospital, and then you would re-consent for that the day of the procedure. There's a ton of issues there, and I could get off into the weeds here with issues of what's called proxy consent, is that we're allowing parents to consent for their child, and that's because we believe that they're acting in the best interest of their child, and that the alternative has a high degree of causing harm. That's clearly not the case here, right? The alternative is simply waiting and doing nothing, and has, aside from really what's a theoretical risk of phimosis and paraphimosis and things that can be readily treated, maybe a higher risk of urinary tract infections that are all, if they occur, they can just be treated, but really much less invasively. But instead, we allow this proxy consent. These parents are not informed. I would argue that mothers who are making this decision probably do not have decision-making capacity, because they have just gone through probably the most emotional experience of their life, especially if that's their first child. They're in a great deal of pain, probably very sleep deprived. So this isn't when no one would come into the hospital, no lawyer would come into the hospital and get a will signed by a mother who was 24 to 36 hours postpartum.
No, that wouldn't even be legal. And a survey done by the Intact America has shown that the average times that the hospital will ask the mother is 8 times asked. And if that's not a hard sell, I don't know what is.
Yeah, it's really right. I mean, do car dealerships even ask you that many times if you want to finance your vehicle?
If you walked into a car dealership and they asked you 8 separate times, you would probably get mad and leave.
And so unfortunately, if that mother takes her baby and leaves the hospital, they're probably calling Child Protective Services. And I don't know that you can easily walk into another hospital and say, hey, I just delivered a baby. I didn't like the care I was receiving over across town. I'm here now. They'd probably look at you cross-eyed.
Leads into the next question, actually. What does intactivism need most right now?
So I think that's 3 things. I think we need clear common goals. We need intentional language, and we need more collaboration. I think I'll take the language part first. So we talked about this in the beginning a little bit. We don't want to be using this normalizing or medicalizing language. Circumcision, cutting around the outside, right? We need to use terminology that's accurate but doesn't normalize or medicalize this procedure, and find that the mutilation or cutting are both good options. We should call it a foreskinectomy or a prepusectomy. We don't talk about that. And actually, I think appendectomy is interesting, right? There was a time, and I have a great aunt that told me about this once, that she had met her husband and they were planning to get engaged, but she actually still had her tonsils. And at the time, a woman was kind of not fit for marriage until she had her tonsils removed, her appendix removed, and her gallbladder removed, because all of those are common causes of problems. And they are. And they're all very simple to remove if they do indeed cause a problem. We absolutely don't routinely do those procedures on anyone anymore as primary prevention. Again, those are all 3 very common diseases, some of which can be treated medically, some of which require surgery. They're all minor surgeries. And the other thing we know is that we know that these are all organs that have function. and that despite them being predisposed to high rates of negative consequences, we know that the tonsils have a very important immunological function, probably have some role in preventing and fighting cancer in terms of their lymphatic tissue. We've learned in the past several years about the roles of the appendix along similar lines in immunological areas. And then the gallbladder has some very important roles in digestion. And so if these organs are not causing you problems, there's absolutely no reason to subject you to the risks of surgery, which are minor, mostly related to the anesthesia for the surgery. But there's no reason to subject you to surgery to remove functional organs because they result in high rates of negative complications. We just manage and treat those complications as they occur. And if you were to develop appendicitis, we would remove your appendix. Actually, 5 years ago, there was starting to be a shift in the medical literature. There was a lot of literature on the medical management of acute appendicitis. So we thought there was going to be this approach, and it was studied that maybe if children especially or healthy young adults come in with appendicitis and it's their first time having appendicitis, that maybe instead of doing surgery, we give them antibiotics and watch them and see if it resolves. And what the literature found actually was that most of the time they do resolve. And so there started to be this change in management of acute appendicitis in healthy young adults and in children towards antibiotics instead of surgery. And then as we continued to study these patients, we realized, though, that those patients had very high risk of having appendicitis again, and that it appeared that each additional time they got appendicitis, their risk of having severe outcomes or having a perforation seemed to get higher. And so the pendulum has swung the other way, and we've said, yep, we need to remove it. We've also learned, though, that it's not an emergency. We can get, especially if people aren't perforated or don't look like they're about to perforate based on exam findings or CAT scan findings, we can give antibiotics and we can do that surgery. We don't need to do that in the middle of the night in a healthy person. We can do that the next morning when the entire operating room staff is wide awake and caffeinated and everyone's on their normal circadian rhythm, and actually probably better for the patient, better for the staff, and just takes the stress level down. So we've learned a lot from that. That has changed practice. But as my aunt, who's in her 90s, she was getting aged, this was 70 some odd years ago, we don't routinely remove the tonsils, the gallbladder, and the appendix of young adults so that they can, move into adulthood. That's not something we do. And so
there's only one prophylactic surgery in the United States.
Yeah.
And that's foreskin removal.
Yeah. And then, people love to point out, mastectomy is for breast cancer. And I say, we do mastectomies for breast cancer risk for a very, very specific population, for women who have a BRCA mutation that has been tested, usually because they have a family history. And, we know so much about those mutations now, probably the best studied genetic mutation in humans. I might be wrong on that. Again, not a geneticist, not a breast surgeon, but we know that these women are at very high risk, 70-80% risk of developing breast cancer over their lives, very high risk of developing ovarian cancer. So we are selecting a subset of a subset of women. We're doing this in adulthood to a woman who's consenting to this procedure after extensive counseling. That the standards for this are that the woman meets with a genetic counselor who talks about genetic risk factors, that the woman meets with a a surgeon about this, who talks about the surgical risks and benefits. So this is something that we're doing an extensive amount of selection and then an extensive amount of informed consent on. And again, a child cannot provide informed consent, and proxy consent is not acceptable in a non-emergent situation, in a situation where the alternative does not put the patient at an extreme risk. If your child has appendicitis and they need to have their appendix removed, that's an appropriate utilization of proxy consent. You can't consent the child. You can consent the parent, and you can say, if, and again, based on this literature, I mean, maybe appendicitis isn't the best example now that we talked about that. If your kid has a broken leg, we can say that severely displaced, a broken femur. We need to do surgery to fix his or her femur. But this is a situation where I would argue the result of waiting and doing nothing is a better outcome, is avoiding harm, is actually better for the patient. And so it's just not acceptable.
So you talked about the clear common goals.
So I think our three things are clear common goals, intentional language, and more collaboration. And so I talked about language, that we don't normalize or medicalize this. We use accurate language. I think in terms of our goals, I think we really, as an intactivist movement, need to move towards positive framing. And so that instead of saying end circumcision or end cutting, I think we need to say, what do we want? And what we want is, however you want to frame it, genital autonomy or bodily integrity or whole child. We want to frame what we want in a positive light. Instead of saying what we don't want, we want to say what we want. The third,
movement for wholeness.
Yes, movement for wholeness. Great. And the other side of that is we really need to have more collaboration. We have a vast array of primarily grassroots organizations, and that's great. But the organizations are not communicating with each other, so the right hand doesn't know what the left hand's doing. There's no unified messaging. So again, not just the positive framing, but then let's come together and let's agree on that, how we're going to sell this in that positive framing. And I think some of that comes from the other issues. And it's very much important that we maintain a singular focus on genital autonomy or bodily integrity. And we put aside these other issues. We have people who are on the right politically, people who are on the left, people who are in the center. We've got to put partisan politics aside. Sexual orientation plays into this. We've got the gay part of the anti-cutting movement, and I understand why we have that. I mean, I've asked some gay men in the intactivist movement, why are there so many gays in the intactivist movement? And they said, Jared, who do you think spends the most time thinking about penises? Okay.
Well,
fair enough.
How I realized that why there's so many homosexual men in the intactivist movement is because they've experienced a whole penis. I have never experienced a whole penis. Mine was cut off hours after my birth. How would I know what a whole penis was supposed to look like? So a cut man experienced what an intact man, they understand.
Right. That's a very good point. So they might have again, probably percentage wise, I don't know the numbers, but over the course of their lifetime, they're probably likely to have a sexual partner who's intact, and that creates a huge cognitive dissonance. I think the probably initial instinctual reaction, and I'm just postulating here, is, ooh, I didn't sign up for this, but it makes you then start to have that self-doubt. So that's a very good point. I really didn't think about that. And so we've got to get that side of things out of there. We've got to get there's this whole issue around sexually confused children or the transgender movement, which I've spoken out against, and I'm very vocally opposed to cutting on any children's genitals. I don't care if they're 72 hours old or 12 years old. They can't consent, and we need to protect children. Children are a protected class, and unfortunately, that gets muddied into this debate, and people take different stances on that, and so there becomes this infighting on that issue as well.
Well, I don't know what age a child can consent to have their own genitals cut, but we can all agree on that an infant does not meet that threshold.
Yes, we can all come to the table and agree on that.
Yeah.
And then I think the religious side of things is where things get really muddy. Both Jews and Muslims have male genital cutting as a deeply rooted religious tradition. And you have organizations that, for one reason or another, take a position that is very strongly on one side or the other with regards to that. We must end routine male genital cutting, but if you're doing it as a religious exercise, then that's okay. And then we have people who say, no, we must end all of this. I think we need to stay very mission focused, and we need to get out of the weeds and not even get into the religious debate. Let's just stay very focused on we are here for genital autonomy, bodily integrity for all children, and just leave it there.
That's something we can all agree on, I think.
Yeah.
So you as a doctor have a unique perspective on, because of your background, of what the mental, physical, and emotional harms of circumcision are.
I'll start with the physical, if that's okay, because that's easy, right? So it's removal of what will grow to be a 50 square centimeter piece of skin. So that's the size of a Post-it note. I don't think I have any Post-it notes on my desk.
Size of your cell phone.
You're amputating what will grow to be the size of a Post-it note. And along with that, that's not just skin, but along with that, you're removing 70,000 slow conducting specialized C nerve fibers, and you're replacing that with a scar. And scar tissue is inherently less mobile, has less blood flow, has minimal nerve endings. So you are removing this innervated piece of skin and replacing it with a scar. So what's the functional loss there? Well, you have a loss of sensitivity because you've just removed 70,000 nerves. You have a loss of protection of the glans penis, chafing from the underwear, from the zipper, from all this stuff. You have the glans penis, which is now exposed, not only drying out, but actually keratinizing. So you have keratin formation on the head of the penis, on the glans penis. So keratin is the difference between the skin on the outside of my cheek and the inside of my cheek. The inside of my cheek is a mucosal skin that is not keratinized. And the outside of my cheek is keratinized because it faces the outside world. That's what you're doing with the glans penis, is you're drawing it out, and this hard covering of keratin is forming over it. And you're losing that gliding action that the foreskin provides. The foreskin provides a natural barrier. I'm a mechanical engineer. Before medical school, I studied mechanical engineering and chemistry. And we talk a lot about bearings and lubrication. Why do we have such an industry that's focused on sexual lubrication in the US? Because most men are missing their bearing that naturally provides a decrease in shearing when engaged in sexual intercourse. And it's not just vaginal sexual intercourse, but it's oral sex and anal sex. So you're losing that gliding action. So you have a physical harm with a loss of functionality, right? Really easy. And you mentioned the mental and emotional harms, and that's really hard, right? This is not an area that's well studied. It's not easy to study, because how do you study the mental and emotional harms of someone who's 36 hours old? You can't talk to them. You can't ask them. But what are you doing? You're taking a newborn baby away from his mother and his father, and you're strapping him down into a circumstraint that looks like a medieval torture device. You're strapping down both arms, strapping down both legs. You're then taking a pick and lysing these adhesions, these normal adhesions that occur between the prepuce, the foreskin, and the glands of the penis. And these adhesions are present. They're present in females between the clitoral hood and the clitoris. And as sex hormone levels increase around the beginning of puberty, these adhesions start to break down. These are almost never something that the medical system ever gets involved in removing. These just break down with age. Not a big deal. But you're going in and lysing these. You're tearing skin from one side or the other, and you don't have control over which side that's coming off. You're taking the epidermis, the top layer of skin, off of the glans penis while you're doing this. You're already causing bleeding by doing this. Then you take this barbaric clamp and clamp down the foreskin to demarcate your lines, to protect the glans penis, which you've just irritated and ripped away the protection of. And this clamp is also intended to limit blood flow to the foreskin so that you're, hopefully having less bleeding. And then you use a scalpel to amputate. And I guess that I'll take that word too. I'll add that to my list: mutilation, cutting, and amputation. To amputate this very nerve-rich tissue with little more than a drop of sugar water in the mouth,
Which
for distraction.
All other medical procedures, sugar is a known placebo.
Yes.
But yet they try to say that sugar water is an antiseptic for an infant child. When
anesthetic, so it's being anesthetized to prevent pain, not to prevent infection, and it's given in the mouth. I mean, at best, it's a distraction. It's candy for a baby, right? It's here, suck on this, and we're gonna cut the protection.
Which some of the videos I've seen is more of a waterboarding than it is anything else.
Oh, absolutely. And if you look at a circumstraint, I mean, that's what it looks like. Put an adult in a circumstraint and see what people think about that. So infants are typically seen 2 days after they're discharged from the hospital by the pediatrician, who may or may not have been the one to perform the surgery. It may have been the obstetrician, or it may have been the pediatrician. I think that the rates are probably like 80% obstetrician, 20% pediatrician, which is really surprising because the obstetrician's role really ends when the baby's delivered, right? The baby's delivered, the umbilical cord is clamped and cut, and then the baby gets handed off to the pediatricians. If it's a preterm baby, to the neonatologist. The obstetrician is responsible for managing the mother, for delivering the placenta, for making sure that she doesn't have extensive bleeding, that if she has any tearing, that's repaired. But really, the obstetrician's role ends. And then for some reason, in 80% of cases, based on some literature I was just looking at, that obstetrician injects themselves into this child's life and cuts off his foreskin.
I've always thought that was extremely unusual, how the doctor who is specialized in women's fertility and childbirth is now cutting the genitals of a male child.
Very strange, right? A doctor who does not take care of men, by definition, is cutting the genitals of male children. And you do see pediatricians doing this as well, and I don't think it makes it any more defensible at all. What I was very, very perturbed by recently is I was actually at a Jewish event last week, and I was speaking to a fellow Jewish physician who has 2 sons who were both cut in a Jewish religious tradition, but by a physician. He was telling me that he was aware of a case where this went poorly. And this was actually not a physician that was performing this. This was actually a moil who can be a physician, can be a rabbi, can be neither, but it is a learned Jewish man. I think in some streams of Judaism, women, but primarily men and historically men, who perform this. And in the Jewish tradition, this is performed on the 8th day of a boy's life. There's a lot of significance to that. And it is actually the only thing in Judaism that has to happen on that day, no matter what else is going on. If it is the holiest day of repentance of the year, if it's a funeral, if it's the Sabbath, you are commanded to put every other Jewish law aside to make sure that that baby boy's penis is cut on his 8th day of life. But honestly, in so much of the American Jewish tradition, this isn't done on the 8th day. It's done in the hospital. Doesn't make it any better, but using this Jewish tradition as a justification for something that's not even following Jewish law just further disgusts me. But he was talking about a case where this was performed. It's, again, a very small area. Before puberty, the penis is very small. You've got a very small child. And what happened in this case is the mohel applied the clamp and ended up amputating both the foreskin and the glands of the penis, the entire head of the penis of this boy. Immediately, he had to be rushed to a hospital and then was sent to a pediatric hospital. Urology got involved, plastic surgery got involved, the microsurgery teams got involved. This kid is now, I think, 10 to 12 years old, has had 6 total reconstructive surgeries on his penis. Known what he's, of course, prepubescent or peripubescent now. Who knows what his sexual function is going to be like, but it's never going to be normal. And for what? And there's reports of boys that have undiagnosed hemophilia. You're doing unnecessary surgery on an infant. There's reports of infants who have bled to death from this procedure. And you would say you shouldn't bleed to death from it. Yeah, you shouldn't bleed to death from it. Absolutely not. But if you have a clotting disorder, this is a really bad way to figure out you have a clotting disorder. And we actually test for these clotting disorders. It's unfortunate, but in each of the 50 states and DC, the state actually mandates what genetic disorders we test for at birth, and they have a panel. And so one of the things we do is we get a sample off of a pinprick to the heel of the baby, but it's done shortly after birth. And the blood is sent off to a state designated lab and tested for a bunch of different genetic abnormalities. And I can say very confidently that the vast majority, if not all of the states, test for hemophilia, amongst other things. And so within a few weeks, the pediatrician gets back a report that says if the kid has any of these genetic abnormalities that are detected. And if so, they can get on top of that. Some of these are very severe metabolic disorders that require special diets or special medications, but that you can identify those early, right? If you send that blood off and then the next day proceed to amputate his foreskin and you don't have the results of your hemophilia test, which you won't, it takes, I think, probably at least a week at least a few days in the best case scenario, probably week to 2, depends on the state. Why are you doing this? Why are you bothering to send off a test if you're going to take an action that you wouldn't otherwise take based on the results of the test? And we say this in medicine all the time. Is this test indicated? We do a lot of unnecessary medical testing. And one of the questions you need to ask yourself as a physician or as any sort of practitioner, nurse practitioner, PA, is how will the results of this test change my management? So if you're not even waiting for the results of the test to come back and you're doing something that your management would change, it's like, whoa, there's a huge problem here.
It is very easy for the child to bleed to death, and a scenario could be very much that the mother has just had a baby a few hours ago, really, and she's tired. The baby gets circumcised. A baby only has to lose 2 ounces of blood. A modern diaper will absorb 2 ounces of fluid very easily. She goes home and the child is, oh my God, he's finally sleeping. And she gets to rest a little bit. Well, he's not sleeping. He's bleeding out.
Yeah, and I will admit, thankfully, bleeding complications from genital cutting in males in the medical setting in the U.S. are very rare, or exceedingly rare. But again, why are these are all non-zero risks, and not even the risk. These in the best case scenario is that you are strapping down a child, making him cry, making him bleed, removing 50 square centimeters of tissue, removing 70,000 nerves, and leaving him with a scar. And like how do you sell this to someone? And you don't. That's exactly what happens here. We don't have an informed consent system. We don't, because if you had to talk about this, no one would agree to it. And why don't we see men in Europe? Why don't we see men in Asia going to get cut as adults? Oh, well, the American, explanation is, oh, it's painful and it requires anesthesia, it's expensive, and so no one wants to do it. I'm like, okay, so if this was really beneficial, you would think that there would be high rates of men seeking this out in countries where this wasn't standard practice. And that's just not the case. There are the vast majority of this world, from developed nations to the third world, men manage to get along just fine. Actually, I would argue better, a better sexual function with their entire intact body as they were born.
And not only men, but 5,000 species of mammals on Earth with a foreskin seem to be just fine, but somehow it's the American male is the only one that needs immediate genital modification.
Right. I mean, if you were to take your dog in, I saw this comic recently I really enjoyed. It was a veterinarian with a male dog, and the vet saying to the dog, we're gonna cut off your foreskin because you need to look like your owner.
Oh, please send me that.
Oh yeah. And this is so much of, right. We asked about the emotional harms and the mental harms, and so much of this is really intergenerational trauma. It's the cycle. It's the same cycle as domestic violence, domestic abuse. That if your father abused you, you're likely to abuse your spouse. You're likely to abuse your children. That we have this cycle of perpetuation. So if you are, as a male, cut, you're going to cut your children. If you cut your first boy, you're going to cut your second, third, you're going to cut all your future boys. And I think as a woman, this gets to be awkward. Is this the man's decision? Is this the woman's decision? I've learned that's very interesting. Usually the couple's like, well, the woman's like, I don't know, I'm not the one with a penis. And so this also becomes this weird interplay between the husband and wife, the mother and father now, of who is making this decision. And again, it's framed in terms of the default decision being to cut. And that's just unacceptable.
Well, Skip, we were going to talk about the future of intactivism, but what you're speaking about right now leads into what message do you wish every parent heard before making the decision?
I think the very simple part of it just goes back to very basic medical ethics. And I've got a pin. I actually sometimes wear it on my white coat. When I moved a few years ago, I misplaced it. I haven't found it. I need to find it. But it said very clearly, his body, his choice. And I had a lot of people, mostly women, ask me, what does that mean? And I said that a man should decide if he's having any body parts removed. I agree that adults have autonomy and adults are allowed to make their own decisions with their own body, with their own money, and are allowed to make bad decisions, whether that's drinking too much, gambling, getting tattoos, or having parts of their body modified or removed. We can get into the complicated medical ethics of this. I think that it is highly immoral and unethical for physicians to have any role in this sort of cosmetic body modification, even in consenting adults. Um, and, that's why you go to a tattoo artist or a piercing professional. You don't go to your doctor's office to get, although I'll say some pediatricians do pierce ears of kids. I'm not thrilled with that. But adults are allowed to make their own decision. I think what you say, this is not medically necessary. This doesn't need to happen now. And if he decides at some point that this is something he wants, great. But I think it just comes down to very simply his body, his choice.
It's a very simple message that if a child cannot make a informed decision and consent for himself, that we should not be modifying their body. Everyone can agree this is a body modification on an infant. How do we get men to speak openly about this? Men are so closed off and they don't want to talk about this. How do we get men to speak about this?
I mean, it's not the masculine thing to do to speak about trauma or to speak about loss, right? It's not manly to cry. And it's very hard. And then when men do speak out about this, they are unfortunately widely dismissed, not just by the population at large, but they're dismissed by the medical community. I've spoken with the urologists who did not know I was involved in the intactivist movement. Hey, what do you think about these guys who say we shouldn't be cutting baby boys? And mind you, urologists are primarily not involved in doing this on children. They are primarily the ones who do this on adult men, whether they decide to have this done electively or cosmetically, sometimes at the pressure of a spouse. I spoke with Leslie Elliott, who's a wonderful counselor and life coach out of the Pacific Northwest, who actually said that at one point during her training, she was asked by a friend to accompany her and her son to a urologist appointment because her friend's son was struggling with phimosis, and her friend was concerned that the urologist would push for a circumcision. And in fact, the urologist did push for a circumcision, and Leslie and her friend pushed back and ended up instead using some topical steroid cream, and his problem resolved with some cream. And he has since grown up to be a healthy adult male with no issues. And so sorry, I'm getting off on a tangent here, but urologists are rarely involved in this, right? The vast majority of this is done by obstetricians and gynecologists, and then by pediatricians. Urologists are the ones who are doing it in children, in adult males. And so I asked this urologist, I said, what do you think about these men who complain about, their genitals being cut? And he said to me, these are really troubled men who are blaming all of their life problems on something that was done to them as an infant. And so and this is the common thread in the medical community, that if you complain about this, you have some deep-seated mental illness, some deep-seated trauma, and you are projecting all of your problems onto this. And so it really forces you into this position where we can't talk about it, because if we talk about it, we get called out. It's this no-win situation, right? The same thing I talked about with how do you address this with people, right? How do you address this with expectant parents, with parents who are expecting a boy or who don't know the sex of their child? How do you address this? And it's a damned if you do, damned if you don't situation, as I explained. I think that as men, talking about this as well is unfortunately the same situation. It's damned if you do, damned if you don't. You can't win.
I agree, because trying to bring this up to other men, and it's like they don't want to talk about their own harm, or they don't want to admit they were harmed. Now,
right.
I'm fine that we get from the normally amputated male in the United States is you might be fine, but you're not excellent.
Yeah.
So they don't know what they're missing. I like to use the analogy. It's like asking a blind man to explain the color blue. it's impossible. That they don't know what they're missing. So, and I want to be respectful of your time, and I want to get into the very difficult question. On the last question we had was, how do we address the anti-Semitism claims that are directed as to us as intactivists?
Yeah, Dwayne, I hope you're not holding on too much hope here for me, because I haven't, I said, you asked me, what's your unique approach for how I speak to someone about cutting for the first time? And I said, I haven't really figured that one out either. And I haven't, this is a really hard issue to address. I talked about in the medical community, everything's open for debate. And this is, for some reason, the one area we can't talk about. We can talk about, even more contentious and political issues like vaccine hesitancy, especially in the post-COVID world. In the Jewish world, there's so much questioning, and this is one of the things we just don't question. I think that coming from a practicing Jew, the message comes off better. I mean, I've been called a self-hating Jew, a Jewish anti-Semite. I mean, I've gotten all the slurs online. I was recently kicked off of a Jewish dating website. They found a video that I had done speaking out against this, and they reached out to me and said, just to clarify, you believe that this is wrong for non-Jewish boys, right? And I said, no, I believe this is wrong for all boys. If a man wants to decide to do this, that's fine. They said, wait, you don't support this being done on 8-day-old Jewish boys? I said, no, not at all. I'm vehemently opposed to it. And they said, you cannot be on our website. You are bringing Kalul Hashem, shame to God. It doesn't translate well. I mean, it is like the worst thing you can utter to a Jew, that you are bringing shame to God's name. I was kicked off this dating website, which is interesting because it's Jews of all streams, Jews who are very, very observant and very, very orthodox in their practice. I was seeing all these women on there who say, I'm culturally Jewish, not observant. And it's like, you're gonna kick me off a website, but you're gonna, say to this girl who's culturally Jewish, who claims to not be religious, that this is okay.
It's so circumcision, if I understand this correctly, is one of the mitzvahs, and there's only 2 of the mitzvahs that are actually practiced out of 108 or 3. Please, if you could clarify.
No, so there's 613 mitzvot in the Torah, and these are the Old Testament, the Jewish Bible. And so no, a lot of these are practiced, and they're not. Mitzvahs often said to be a good deed, but it's not. It's a commandment. Some of these are positive, some of these are negative. So there's 613 mitzvah. Actually, the number is said to be, and I don't know that there's any truth to this, but it's said to be that the average pomegranate has 613 seeds. And so there's some religious significance to pomegranates. You'll often see them adorning Jewish synagogues and tapestries. And so there is some religious significance to the pomegranate, to grapes, to olives. These are all kind of holy fruit. And so you mentioned, how do you address this from anti-Semitism? And one of the things that I heard recently was that instead of cutting the boy, you cut a pomegranate to signify. And so not only is the pomegranate the seed, pun intended, of mitzvot, of the mitzvahs, all 613 of them, but you're also cutting into something that's very red and stains and has a blood-like nature to it. And so I heard that. I think that was kind of interesting. I had in 20...
I'm laughing on the inside over here because pomegranates are actually very good for nitric oxide production in the human body, which is excellent for erections. So,
pomegranates are major antioxidants. We talk about the health benefits of pomegranate, but yeah, so that was something that I had heard, which I was impressed by. There is a movement towards what's called Brit Shalom, or the blessing of welcome, which is kind of similar to what's done for baby girls, because baby girls on the eighth day of life have it doesn't have to happen on the eighth day. There's a lot more flexibility with it for girls, but they have a baby naming where they're given their Hebrew name, which is typically after an ancestor who has recently passed away. But they're conferred upon a Jewish name. And this is a very important ceremony. It's the first kind of public ceremony of childhood. And to say, let's kind of do a same thing for boys. Welcome to the world. Welcome to the community, to the Jewish community. Welcome to the family. And we're not going to cut you. We're not going to charge a toll for entry. We're not going to leave a mark or a scar to show that you've been inducted into our tribe. This is something we're welcoming you in as a positive, as an offer, not by force. And so you can do the pomegranate with that. Again, the pomegranate was something new I had heard that could be part of a Brit Shalom. I get a lot of pushback from the intactivist community when I talk about it, but there's something called Hadafat Dam Brit, which is the blessing of blood. And a man who was cut as a child decided to convert to a more strictly observant stream of Judaism. Well, he can't be cut because he's already been cut. So what is done is that a drop of blood is taken from what's ever left of the foreskin or from the shaft of the penis. And that drop of blood signifies the covenant of blood. It's a covenant of blood between God and Abraham. So you can say, why can't we do this on an infant? And some intactivists will say that's nicking or cutting on genitals. I mean, come on, I'm not talking about using a scalpel or a blade. I'm talking about using a little teeny needle, the same thing that a patient with diabetes, an adult with diabetes, or a kid with diabetes uses to prick their finger 4 or 5 times a day. Talking about a drop of blood. Is it inflicting pain? Yes, minimal, momentary, but it's not cutting anything. It's not removing anything. It's not causing a scar. It's just a drop of blood for religious significance. I work in addiction medicine, and we always look at harm reduction, right? How do we reduce the harm that's coming to someone? And whatever that is, there's multiple types of harm reduction. Sunscreen is harm reduction for skin cancer. Doesn't eliminate skin cancer. Seat belts don't eliminate deaths from automobiles. But how do we reduce the harm? So this is a major way of, I say, absolutely de minimis harm that meets a religious significance in a lot of other ways. Why can we not accept this?
And I like that, actually. That is the easy sell. Yes.
It should be an easy sell, right? If I'm to have a boy one day, I think I've started to question it, but I think that's what I would do.
That gets away from the anti-Semitism as well for us as intactivists. We're not telling you to stop the ritual nicking or drawing of blood for this 8th day. We're just maybe we can do this lesser version of it, and that is an easier sell, and I like that.
And the other sell I try, I don't think many people are willing to listen to me on this, but I'll say wait until his bar mitzvah, right? When a boy turns 13, he's a bar mitzvah age. Does he have capacity to make his own medical decisions at 13? I would argue no. I think we have a very strange standard. It's 18 for most things. For some reason, alcohol, it's 21. The frontal lobe isn't developed until 25 in women, maybe 30 in men. We can get into the harms of marijuana in the developing brain, and that's been 18 or 21, depending on the state, and all kinds of issues there. But if at least you delay this and you give him some degree, it may not be complete autonomy, but that he has some awareness and he can at least have a voice in that decision, I think you have, again, reduced harm. And the response is, well, no 13-year-old boy is going to consent to having his tip of his penis cut off. And I said, well, I don't disagree with you. So then we're doing it at 8 days old, because we're not even doing it at 8 days old. Again, the majority of American Jews are not doing this on the eighth day of life as commanded to. They are not following the mitzvah, the commandment, with the exception of the 20 so percent of the most observant Jews. This is primarily being done in a hospital, and that's typically done between 36 and 48 hours of birth. It's typically like one of the last things before a baby goes home with mom.
Thank you, Dr. Jared. And I appreciate your unique perspective and your experience with us as activists. And I want to be respectful of your time. And I want to thank you for being with me today. And you've brought several realizations, and I thank you for that.
Dwayne, thanks so much. I definitely want to be respectful of your viewers' time. Do you mind if I just end on some closing thoughts here?
Please.
You would ask me what gives me hope for the movement today and moving forward. I think there's three things that are happening. There's definitely increased awareness now. And as I mentioned, we're seeing decreased rates of cutting, specifically in the Pacific Northwest. There is starting to be mainstream questioning among mothers, particularly well-educated, liberal white women, and particularly among the Black community as well, questioning this practice. And so I think that's given me great hope that there's increased awareness, decreased rates of cutting, and increased questioning. And along with that, I'm very excited to see Secretary Robert F. Kennedy Jr. in his position. He is not a physician, is not a medical professional, but what I'm very impressed with is his willingness to question. And there is no one that he is afraid of offending. He has no sacred cows, as he has demonstrated. He will question anything and everything. And so I think when you start seeing leadership from our government that says it's willing to question everything, then cutting is something we can question. And that gives me a great deal of hope. And I think some of this legal action that Klopper and Intact Global are pushing forward, and some of the lobbying efforts that we're seeing out of Intaction, I think this is really increasing awareness, but also increasing this push for penalties. So it's not just a carrot approach, but it's also a stick. And I think that you need to come at this from both sides, raise awareness, but also make this unacceptable and punish people who do it.
That's going to take
And
all
I
of us.
really hope that one day this practice will end, and we will just be able to end unconsensual genital cutting for all children.
That's a great way to end. Thank you, Dr. Jared.
Thanks so much, Dwayne.